to do a comparison of those two codes. However, it's very smart for a billing person in your EEG service area to understand NCCI edits. They're not difficult. They list two rows and they're parallel and they're CPT codes, and it'll tell you if it's a likely approved pairing or not. So let's answer this question, and that is, the NCCI edits state that a modifier is not allowed when billing 95720 and 95816. Okay, so let's back up. What is 95720? It's a professional code. If you look at the CPT code template, and that is listed, that's a professional code, and 95816 is an EEG recording code. And it states then you don't use it on the same date of service. So am I saying to bill it, wait for the denial, and then appeal with notes to support medical necessity? No. The 95720 is the professional interpretation. It is not diagnostic. NCCI edits do not accept a modifier, since this is a dedicated code that differentiates it as a professional code. Now, I want to be sure that we also understand this next piece. Professional codes are usually submitted by the provider. In other words, the one who interpreted the study. This is not generally the facility. There are I won't say rare, there are different circumstances in which this would be submitted by the facility that's doing the diagnostic billing. And that could be in the case of an IDTF. Now, I'm going to come to that. I'll describe that in a minute. But for the most part, facilities don't generally employ the interpreting physician and bill for them in what is called a global billing. And this is a real important difference. Let me do some unraveling here. The definition of global billing is you bill the technical and the professional all in one claim and one code. Often, that does not require individual modifiers. However, this question doesn't state that the facility has been approved to bill globally. So I can't say that this is appropriate. For the most part, it is generally accepted that the facility that owns the equipment will bill the technical fee called the procedure, and the physician who interprets has a separate billing for the professional code. So that's why this NCCI edit will not accept a modifier. And I don't know if this is an approved global billing or not. So I hope that that helps to describe what NCCI edits are. If somebody has a more specific question to this, I'm happy to address that. This is a very technical side of billing, but it is also a very relevant side. And kudos to whomever submitted this for understanding and seeking guidance in NCCI edits. That is a very important higher level question, and thank you. Okay, so this is then the slide that correlates with the question about NCCI edits. And I just want to take a minute then for just to say that this is the validation why you do not use a modifier when billing a professional code and the technical recording code. And here's your example that shows why this is done. You'll notice 95720 is under the professional category, whereas the 9581, the technical code, in other words, 95816 is for the recording of the study. I just want to be sure that you see where I got that 95720. Does this help to clarify what we're talking about? If there can just be a wave of the hand or hands up or just acknowledgement, I just want to be sure. Because this is really where the crux of good coding comes in, are these tables and are the individual differences in terms of technical services and professional services. And I presume then that we can move on. Is that correct?
Yes.
Okay, thank you. Appreciate it. Okay, we're going to talk a bit about IDTFs and how that differs from a hospital setting. This was a question for clarification. Kudos to whomever asked this, because this is really an important difference. And we do see IDTFs. CMS defines these. And IDTF stands for Independent Testing Facility. And it's usually, it's a non-facility based location. Let me describe the definition of facility. CMS regards hospital, hospital property, hospital service, hospital owned as facility. IDTFs are not hospital facility owned. They're a non-facility outside the hospital setting, outside the hospital campus. They can be a fixed location or a mobile location. If the diagnostic service is provided in the physician's office, coverage and payment policies apply, as it is still considered an IDTF. There's been some question over the years that if you're a physician office providing the diagnostic service, that qualifies under an independent physician practice designation. That's not necessarily the case. And this is why I think this is an important question. And that is, you need to confirm if that physician practice has applied for the specialty designation of IDTF. They really do need to apply for that. The only exception is, please hear this clearly, is if the physician is doing diagnostic testing in their office only for the patients the physician sees. If they accept outside referrals for diagnostic testing, then they need to be classified as an IDTF. And then they also need to confirm that they don't share space nor diagnostic equipment with a Medicare enrolled provider or organization. I really should highlight that in yellow because that's critical to this definition. And I think that's where some of this overlapping confusion or question may come in. And this has been a long-standing point of review and question by the Office of Inspector General and by CMS. as an auditor, when I do review different settings like this, I will look for proof that the IDTF has been validated and they are serving outside patient referrals and not just the physician's own patients. And another important part for IDTF is if they have multiple locations, each one of those locations have to have a separate enrollment application and certification by CMS. So this is a little more complex than just saying I'm an IDTF. There's a lot of other variables that go with the approval of that status. And I think then it's important, let me go to this question was raised in the first session, and this is also a very important comparative question. So in an IDTF, do we always have to use a registered tech to set up all Medicare patients? And yes, that's the answer, because now you've seen that they have to be sanctioned and approved by CMS, even though they're independent of a facility or a hospital-based, hospital-owned, hospital property service. So I hope this helps to drill a little deeper into what the IDTF requires and why it's that designation. And to clarify that, I think this is really an important part when you look at IDTFs, but you can look, and this is an important question across the continuum for long-term monitoring and EEG services. You're going to fall under the same requirements that if it's unhooked and then rehooked up within the 24 hours, do you bill a separate study? Or is it a continuation of just the previous study? Okay, it doesn't matter, IDTF or hospital-based at this point. Let's look at what the answer is. So I want to be sure that you see that, and this is some of the validation. So let me go back and say, I don't know if you bill the continuation of the previous study. I have to see what the amount of time for it being unhooked is. Now, what's the medical necessity for billing that continuation of the previous study? Is it within that 24 hours or is it going over to the next day? I'm going to say, and please understand, this is generally, but not always. Generally, if there is very little time between that continuation, in other words, unhook, rehook, if there's very little time between that, you would bill within that 2 codes within that 24 hours, because they're probably not going to be the same CPT code. It could be different duration of time. However, if it goes past that 24 hours, then you definitely would have a separate study. Now, this question has a lot of caveats to it because this question alone doesn't give me enough information. But I want you to be able to, at the end of this presentation today, hopefully understand some of the nuances in this particular question. That question always gives me a scratching in my head because I look at it and I say, I need more information. Let's go to another question. For long-term monitoring codes, under the language of continuous, it says, if there is a break in real-time monitoring of the EEG, the study is intermittent. However, on page 9 of NAC, it says, if somebody goes for an MRI, can you still call it continuous? Can you provide clarity? Oh, I sure can. And I hope you all understand that I love this stuff and I want you to know it. And I want you to be proficient. I want you to take my job from me, because then that tells me that I've been successful in educating you. And the key words here, keywords are video recording and EEG recording. They are different. Now, you have video recording, which can continue without an EEG recording. Can an EEG recording continue without video recording? Sure. But we're talking about what is the definition of video monitoring, video and EEG recording. So if your monitoring tech performs intermittent, continuous, or real-time monitoring, then you need to be able to qualify. Was there a continuous video with EEG, or was one or the other discontinued? Here, the longer interruption cannot be more than, it has to be less than 20% of the total study. Okay, so what are we saying here? It's important for you to know the difference between recording of video and recording of EEG. When I look at documentation on this, it is rarely clear to me. I routinely have to answer the questions. Also, I don't see documentation of time. I can calculate documentation of time. But if you have a reviewer who is looking at this, they're not going to take time to calculate it. They're going to have an expectation to see that it's easily documented. So if the monitoring is interrupted, then it is billed as intermittent. So the take-home message is recording versus monitoring are not interchangeable. I want to see hands up, please. Does this make sense now? Can you tell me that you now understand this difference? Please, hands up. Maybe you can share with me that that's the case. I don't see the attendees.
Yes, we're getting some that are raising their hands there for us, and a lot of them are commenting yes.
Okay, this will be on the post-test. We have to have some levity these days, folks. Okay, let's look at another. Let's look at location of services. I find this to be an ongoing challenge, and some of the questions that were presented from the last part one really reflect location of services and DRG and APC billing. And I get this. This is not the easiest factor in billing. Yeah, and yet I hope that I can clarify this now in a different way. So facility, hospital, inpatient, outpatient hospital, all of those consider facility. So where's the location of services? What do you charge DRGs for, and what do you charge APCs for? And I've clarified here on the left side of the slide. DRG are inpatient services. APCs, that means outpatient facility-based studies. So go back to your definition of facility. And so this means that it is a designation of that patient. You do not declare the patient outpatient. It is the registration that declares a patient outpatient or inpatient. And one of the questions I frequently get is, well, the patient's in the EMU. That EMU is inpatient. Well, but the patient may be a different category than inpatient, and hence they would be considered outpatient APC billing, even though they're in the APC or in the EMU. I don't know without looking at their paperwork and the definition of their admission, if it's outpatient or inpatient. There's also another category. There's 3 categories of a patient's status when they're brought into the hospital for services. So this is a little more technical. Again, this requires a revenue integrity consultant to help you to define this. And I've got another slide coming, so I think I'll answer another question that might be looming on your minds. But the impact of this is one set reimbursement, and this is all based on something that's called the hospital cost report. And this is a cost report that is sent and based on CMS guidelines, but it's also done by your hospital revenue integrity team. So this is a calculation that is outside of the scope of the EEG service area. However, this is an average value of reimbursement based on similar procedures and similar use of resources. It does exclude the professional fee and includes all technical and facility expenses for the service. So let's look at how that can be laid out. Changing the patient to the inpatient status can constitute fraud. If this is to be billed under APC rather than DRGs. So this is an important reason why we would not necessarily assume that a patient in the EMU is inpatient. And this may be why your patient is being, your revenue integrity team is asking you, this is billed under APCs, that's outpatient. And you're saying, but we're in the inpatient location. Now, one exception may occur, and that is the EMU monitoring location. Or there's also special occasions where there may need to be an admission to inpatient status because of the acuity of the patient, the monitoring that's required, and the addition of a licensed clinical provider on site at the time. And I give you probably the most common reason this may be done, and that is titration of the anticonvulsants or weaning from one class of the anticonvulsants to another class of anticonvulsants. That is generally the reason that they might be in the EMU and considered an inpatient. However, this can't be defined at either or. It's always an exception that has to be evaluated with your revenue integrity, and it's based on the diagnosis, the incoming procedure, and the need for licensed clinical provider or supervision. So what's your best practice here? You really need to bring in your revenue integrity team, and another part is you can want to compare reimbursement with each insurance, and this is important. Calculated a weighted impact of revenue versus your insurance class versus your APC reimbursement. That's a mouthful, isn't it? And it's not just for the tech. It is for the technologist. It is for your service area and your revenue team experts to sit down and do this in consultation. And the reason for that is, where's my slide. I guess I didn't put it in there. The reason for this is the APCs have a very different way of calculating them. And I do this regularly, and I still have to sit down and talk with revenue integrity, because every hospital has their own methodology for how they look at this. However, APCs are a standard weighted classification of the CPT code. These are not for individuals to decide. It is a standard classification. I know I have a slide further down on that, but maybe I can use that as a summary then of APCs versus DRGs. So here you have another question. During an inpatient admission, if the ordering physician asks for long-term monitoring, and we charge a setup and 12 to 26 hours, they ask then for the patient to come down and 2 days later back up, same admission. Can there be more than one setup charge in one admission? Can there be more than 2 12-hour in one admission? Yes, but notice what I've highlighted. You can have more than one setup and procedure charge if separated by at least 24 hours. That's straight out of the guidelines. In this example, there are 2 days between the two monitoring events. So that constitutes then 2 separate events. Okay, 95719, I don't know. If it is not stated that with or without video, long-term monitoring by definition is continuous recording. 9570 or 9599, I don't know. There's no documentation of credentials. So this is a classic case in which I implore you to be over the top with your documentation. These yellow highlights constitute required documentation. And when I review cases, if these aren't there, we're going to default to the lowest CPT code for payment. And you're going to say, but then we lose money. Yes, and this is why documentation is so critical. Please, hands up, nods, statement. Now I understand the importance of this. Please, do you see them, Sarah?
Yes.
I'm being really specific here because as we ramp up between part 1, part 2, and part 3, we're getting a lot more specificity.
Yes.
Okay. A question, can we build 2 routine EEGs on the same data services if ordered separately and 8 hours apart? Well, I hope so, but here again, I don't know what the medical necessity is to qualify to do 2 complete routine EEGs within 8 hours on the same day. What would constitute medical necessity here? Put some ideas in the chat. Let's have a little back and forth. I'm curious what you all would say would be deemed medical necessity to do 2 EEGs within the same day. What are some of the documentations?
I'm not seeing anything yet. Does anyone have any ideas that they would like to share with Kathryn and us? Okay, patient in status, but only have 1 computer with multiple inpatient orders to see if meds have helped the patient.
Yep.
Change in status of the patient.
Yep.
Change in consciousness, altered mental status.
Yep. Okay, excellent. Oh, you all take my chair here. You can do this. Excellent. Now,
Do
is it
not have an
documented?
on-site neurologist too.
That's questionable.
Oh, okay.
And the reason being, that doesn't constitute medical necessity.
Oh,
Where does medical necessity come from? The licensed clinical provider that deems it is necessary to move to another routine recording. Now, I would question that that's routine. I think that's a misnomer here. However, I don't see that medical record. I don't see the progress notes, and I don't see the consultation that may be between the neurologist and the attending. You know, the neurologist may not be the attending in this. It might be a critical care provider. It could be the primary care provider. However, this is where it's important to be asking the questions. So I'm going to ask you, clarify and validate. Who is making this determination that it's medically necessary to do another study? And is it documented in the medical record? In the absence of that, it will be denied. Does that make sense?
we got two more that came in too, Kathryn. So one was no LTM service with status in the morning routine. And
Okay.
then the other one was what about before and after neurosurgical ICU interventions?
Yeah. That would qualify as long as there's a documentation in the medical record. And this can even be in the nurse's notes or the provider's notes about update. It also could be in the original order. So I don't know that. I would clarify that. Let me ask you this. How often do you get this information? And I'm probably asking this, and you're all laughing. Seriously? Because I remember those days. However, I need to ask, do you get this information? Do you question this information? Give me some feedback.
We don't have anything yet.
Any notes?
No, no
Okay.
one's.
Yeah.
Oh, here we go. They don't understand the question. Yes, we will talk with the neuro team to clarify.
Okay. So the question is, how often do you get the information that supports medical necessity to do 2 routines in one day? Or do you have to go in search of the medical necessity to be able to validate that it should be done? 2 routines should be done within the same day.
And we do have one that said we would question at our facility with our team.
Great. Excellent. So if there's more to this, send the question in after this because, we'll respond to that. This is what makes good discussion points is we're meeting your needs. So we're really close on time here. I want to get a little bit more done. I apologize with my connection issues. If a routine study gets hooked up in long-term monitoring shortly after ending a routine study, can you bill the routine study or does it become part of the cEEG or LTM? And can you only bill for the long-term monitoring? If a person on cEEG at any length of time, say 3 days, is unplugged and transferred to a different room or a different unit, taken to MRI or CT, does that mean the entire study has to be billed as intermittent monitoring or continuous monitoring? This goes back to the definition of monitoring. LTM needs video and EEG. Do you continue video monitoring in MRI? Generally not, so it would be intermittent monitoring. So I bring this back to reinforce definition of general versus intermittent video and EEG. Here's your requirements for EEG technologists. What does it define? This is the definition that comes from ASET. It's in there on their website. I want to clarify here as a summary of the technical components, what constitutes 95700, and you can see my arrow there. It's very important to look at this from a definition. You may say, does it require an REEG T? I can't answer that because you have to state, is it a Medicare patient, covered patient that you're recording? Is the third-party payer going under Medicare guidelines, in which case, yes, it does. Okay. I think this is the same. This is the same kind of reinforcing that continuous EEG for 2 days, and then you unhook later that night, you want to hook up. No, the hookup fee is billable only once every 24 hours, only once. So I've kind of clustered the slides for today to be focused on some specific topics in hopes that this reinforces and clarifies some of those questions. They're good questions. Please keep them coming. But today we're going to run out. You need to tell me if we continue another 15 minutes. Is that correct?
Is it?
I want to be sure.
15 more minutes.
So I'm going to go on with this one then.
Okay.
You stop me when we need to pull it. Otherwise, I'll continue.
Okay.
So at our hospital, the physicians generate one final report for the entire week of the physician's epilepsy monitoring. We stop and start the study each day to make reviewing more manageable. My question is, do we have to document the patient's medical history, medications, and write a tech report for each individual file? So I need a clarification. How long is the study stopped before it started? If it's a period of time that goes over the 24 hours, yes. If it's only a few minutes, then you would append the demographic data, medical history, medications, and level of monitoring on each individual, on each file. Now, you may say, well, that takes time. Yes, it does. But I'm telling you, this really does reduce denials. Denials take longer to appeal than it does to sit and append the data. It's also a best practice, and it helps to answer the questions immediately for somebody like me who is reviewing these claims. Next one, when the lab documenting the technical component for your EEG EMR software, do you do it in both? Well, it must be documented in a medical record, and that would likely be in the EMR. I'm going to tell you it's important to also document in the EEG software for the interpreting physician to access. And ideally, you're documenting in the EEG software, and that can actually be ported into the EMR. That sometimes works and sometimes it doesn't. So here, what's the best practice here? Ask your HIM people how this information can be transferred from your recording device to the EMR. It's analogous to look at the cath lab or look at the bedside. They port their vitals directly into the EMR. So you could ask for that if that can be done. It might be a software disparity in communication. However, you need to ask for clarification on that. At the best practice is you do them in both. Documentation standards, I get asked, well, what do we document? I think it's important for us to look at some of the key variables that I would look at if I'm looking at your charts. And I'm saying, okay, answer the question before I ask it. Log in, log out. Sure like to see your credentials. It'll answer a lot of questions. Video, no video. Quality of study. Sometimes it's important to document for your physician that's interpreting the impedance checks. Events, seizures. Did you transfer the data? Notice interruption of recording. What's the reason? How much time? Start and stop time. Really answering that documenting that would answer a host of questions on the front end. Notate the time when transition to a different level of monitoring. And completion of setup, remote monitoring of non-EEG versus EEG tech. Does this make sense? Again, a nod, a hands up, a yes, a big yes. I just want to be sure that you understand that this is really such an improvement over some of what we see. And it is best practice, but it's also required practice in most organizations. So do we see a lot of yes, yahoos?
Yeses.
Okay, excellent, thank you. Okay, now you may say, oh, where do we find out all this? Where can I learn more? How did I learn this? This is the home page of the cms.gov. This is where a lot of the information sits. This is where the standards sit. This is where third-party payers go to reference CMS guidelines. And notice I have put 2 red arrows in here. If you see this is a proposed rule, it's not ready yet. And notice the second arrow. When would it be finalized? So notice this is an example from 2019. I gave this as just a reference. You can see in the proposed publication date versus the closure of the final comment period versus then the acceptance of the rule. This is where you find out, is it a rule yet? Has it been proposed and not finalized? You can learn all of that from this page. And this is several years ago, but that doesn't matter. It's always updated for the current year. And I'm giving you this as a reference for you to answer your questions. What are some of the key words in this example, this coding example? And here I'm giving you a little bit of a different approach to billing and coding. Long-term intermittent monitoring EEG recording with video in the home is started on Monday at 8 p.m. and is terminated Wednesday at 7 p.m. Setup is completed by a non-EEG tech observed through remote monitoring. So your total hours are 47, and these would be the codes you used. Okay, what are some of the key words? What is important? I'm going to teach you to be what I look for. Intermittent monitoring with video, non-EEG tech, remote monitoring. Those are the key words. So this is an example of how we would look at a claim. One thing that's important, and bring your revenue integrity team in on this, but the order of the CPT codes matters. you always post the first code as the code with the highest RVU. That means the revenue and code has to be the highest one, the one that pays the most, has the most RVUs, you post first. And in order, second and third are in descending order. You post the second one with the second lowest number of RVUs, and the third one would be the lowest number of RVUs. This is a science, and it works every time. So that is an important finding. And you might ask your revenue integrity team to show some examples of this, because it does have value when you see it on the claim. Question, I have two people that helped me that were cross-trained CB techs. Now this came from our part 1, and I thought it was important to refresh it again. If a long-term is set up by the non-registered cross-trained techs, would the code 95999 need to be used instead of 9570? Well, I'd like to put this out there to have you all answer it, but I gave you the answer. Yes, invite them to study to complete for their registry or their CTLM credential. Make note of this, that continuous recording with video is the definition of long-term EEG setup. So I'm drawing together some of the nuances of the requirements here in this one case study so that you can see how we review some keywords in these questions. That's,
Kathryn, one slide
yes.
back,
I'm
where you
sorry.
have 1, 2, and 3 for the examples. Can you clarify non-EEG tech for the audience right there?
Sure. Yeah, and that's the definition. They're not registered if it's a Medicare patient, and they don't have an EEG job classification. And that goes back to that classification that is provided by ASET.
So such as a nurse or an EKG or somebody else watching the study.
Yep. Okay. Yep. Here's the definition of an EEG technologist according to ASET. Now, I'm going to make one statement and listen carefully. When you have this definition, it is a classification by your HR department. So the reason ASET made this clarification and defined this, and I was involved with ASET when this was occurring, is because we needed to be an advocate for our HR departments to adopt the classical lexicon for definition of an EEG tech. Okay, so if you don't fit into this job class, you're not an EEG tech. What is the go-to here? HR, classification. Your job descriptions need to reflect what HR adopts, and this is a national consortia that defines these. And it's always important for reimbursement purposes that you use that national classification, because that's what CMS looks at. Okay, so if you have EEG Tech Trainee, EEG Tech 1, EEG Tech 2, how is that defined in the national classification? Go to that book and get that information, and then you have a much better chance of not having a question of what constitutes a non-EEG tech. Does that help you?
Yes, thank you.
I'm so glad you're asking questions. Thank you. Okay. Is 24 hours of consecutive monitoring based on date of service? Well, it can be the date of service. There's some variations here, though more and more there's a standard. Most facilities calculate a date of service as from the date, this time it starts till midnight. Clocks move ahead to a new date after midnight, which is why most organizations will drop their claims for the date of service at midnight. So the next day, if there's continuance of service, it is a new date on the bill. This needs to be validated with your revenue integrity team. I personally, when I look at them, I can tell what the revenue integrity team defines as a date of service. It's till midnight, and then the new date starts. Does that mean that your claim has 2 entries? Yes. One for each date in which you're providing services. Okay. The AMA CPT states that 95700 can be billed once per recording period on the date the setup was performed. What constitutes the end of the recording period? What about hygiene breaks? Okay, so a recording period, if it's a short hygiene break, does that mean that it's longer than 20% of the recording? I would say that's a pretty long break. So what constitutes the end of the recording period? That's when you terminate the recording, and it goes back to your definition of recording time. If it's long-term monitoring, then does that mean that you have less than 20%? Is 80% constitute? I can't tell you that without seeing more of the recording. But this is where you begin to drill in to the definitions of the recording. If a daytime monitoring in an office study is 3 hours, can I still bill for the 3 to 12 hour code? Yes, you would bill and report either 95717 to 12 hour recording without video, or 95718 with video for the physician service, for the physician office services. The CPT code is based on duration of time, okay, and with or without. So I think that it's important for you to use that grid that is published in the CPT manual when you're cross-referencing this. Now, this question, I could take this question to a whole nother category of discussion, but I answered this question based on just what it was asking. 3 hours in a 2 to 12, and can you use 2 to 12? Yep. Okay. I could build a lot more with that, but there's nothing else documented. So an importance here is what is documented. Okay, so where do we get that? Here's again, remember, this is your setup grid. This is this is for the technical component setup, 95700, and here's your criteria. You'll notice that it's only once per recording period. And you'll notice that 95700 has a statement that it's a continuous recording with video when performed. And it includes the setup, patient education, and the takedown. And it's administered by a person in person by an EEG technologist. And I also got a question quite some time ago about how many channels. Is it a minimum number of channels? Well, this statement says it's a minimum of 8 channels. I don't think many of us use 8 channels or less anymore. However, there's always variances in this that continue to come forth. Okay, this is sacred. So this particular, I brought this up because it's a real important review. Routine EEGs, let's look at the definition. This is routine. This is the definition. And so this is where you are documenting according to time. And what is the level of awareness? Are they drowsy, or are they actually going into a sleep where you have V waves and spindles? In the absence of that, they're not asleep. They are drowsy. And that old code that's been deleted. So document the amount of time recorded and the stage recorded. That is critically important. In the absence of that, they'll ask you for reports, and then you're delayed in your reimbursement. So here's another key table. Have this on your desk when you're doing dropping your bill, your coding, your charges. Notice the difference: technical service, professional services. And this is a reference to that APC, and this is how you look at it. This is a clarification of APCs. You see the categories. You see the codes that fit into one category. APC 5722, that's a level 2. You see a level 4, 3, and 4. This is your key. This is how you know in the hospital outpatient what payment you're going to get. It is that payment. There's no negotiation. It is or it isn't. Your documentation is critical because that's what drives your payment. Any attempt to change that without the documentation is fraud. So this is why APCs are so important to understand. Again, I can't reinforce enough. Okay. Are the professional codes built on the day of the study is initiated or the day it ends? The CPT code book does not define the date of service that the professional codes need to be posted. But the best practice is you do it the day the procedure starts. But comment here is you need to verify what your third-party payer requires. I know a couple of third-party payers that they want to see it every day of service. So if it goes 3 days, you would have 3 professional codes. I know of one who doesn't want that. They want it at the end of the service. So you need to verify that. And again, most facilities routinely calculate the day ending at midnight. Okay. And this gives you a reference to your IDTFs. It's an article. It's a way that you can look at who is your administrator of your claims for IDTFs. It's by region. And this is where you have your local coverage determination that defines what are the coverage guidelines. And you should have a good relationship with them. This is where you want to talk to their administrators. You want to know what the guidelines are. Okay, who are the influencers? We all are. Know your business. Reach out, collaborate, use your outcome data. Who are your resources, your leaders, your medical directors, your third-party payers, your revenue integrity team? Any questions? Because this is what you need to provide them so that you can stay financially solvent. And some of these words that you might need to learn them, but we can do it as a team. Anything that I can help you with today, and I know we'll have more questions for our third webinar. This is great. This is what it's about. Anything for me?
We do have one. Does that mean that EMU is probably the only actual continuous monitoring eligible charge?
No, no. I can see where EEG can be continuous monitoring charge as long as there's video. And I think, and that's a very good question, and I'm hesitating because I'm trying to think of all plausible scenarios, but I don't think that's the only one.
We can also review that again for part 3 on August 6th, so you have more time and more detail. Another one was, what if Cerebell is charged for setup and 2 to 12 then EEG charges setup?
What if
Cerebell is charged for setup and 2 to 12 then EEG charges setup?
What is Cerebell? I'm not understanding.
That might be one we have to look at then for August 6th so we can get more information.
Yeah. Is that the name? Is that a name?
Cerebell, I believe, is an EEG like headset.
Got it.
But I want more clarification before so we can get the right. Yeah.
It is. And if the patient puts it on, that is defined in the definition of the CPT code. It is there. Okay. This is really good. I will need to have some research on that. I want to be sure I understand the type of setup that is. There's a lot of different setups that can be included in this, and I don't necessarily use product names because I can't endorse, and this could be construed, although as a question, it is not endorsement. So thank you. I'll do some research on that.
Okay. Yeah. So we're getting a lot of thank yous and that this is great information and knowledge, that you're very knowledgeable. Yep. And we'll definitely, that Cerebell, I see some of you have put some information in there for us. So Kathryn and I will review that for the next time. And please share any questions. My email is sbatson, BATSON, at rhythmlink.com. And we will definitely, any questions that come to mind after this, we appreciate you staying on longer. And we look forward to seeing you all August 6th. And Kathryn, you are just, again, as everyone else said, so knowledgeable. And we really appreciate this.
Oh, I'm so delighted to be part of this. Thank you. Anytime.
Awesome. And when can everybody see you live? Are you going to be at any conferences coming up?
Well, I actually was invited to come to ASET this year, and I'm going to be doing a Saturday morning. There's a panel group, and it's focused on credentials. And come up and talk to me. I'd love it. I'd like to put a name in the face. I can answer questions then. I am not going to be there long. I'm going to fly in and fly out for that, but I'll be coming in on Friday night. I bet I'll be walking around, but please don't be a stranger. Yeah. And maybe I can talk you into becoming a coder.
There you go. And our next webinar will be right after ASET. So maybe we'll be able to share some questions there from there too.
Yeah. Good. Excellent.
All right. Thank you.